Good evening, friends. I would like to invite all of you for this API DIAS meeting, which we are conducting today. If I give you the brief introduction of API DIAS program, it's an association of Abbott Pharmaceuticals, Abbott Healthcare, with Association of Physicians of India, which is one of the largest organizations of physicians all over the world, where we are at present having more than 22,000 members. I am the Vice President of the Association of Physicians of India, and I'm the head of the Department of Internal Medicine in 400-bedded hospital of Yatharth Super Specialty Hospital in Greater Noida. I would like to welcome all my colleagues, friends, my seniors who have joined this program this evening. API DIAS program is a dissemination of updated information through API speakers. And I am happy to share that this program with the associations of Abbott is going on for the last 7 years, more than 7 years. Already, there are about more than 22,000 of the physicians and clinicians who have benefited from this program. To start with the inauguration of this program, I would like to invite the dignitaries who would be chairing the dais during the inaugural session. The first to come, of course, is our Honorable President, Dr. S. Arul Raj. He is the president of our association. We are honored to have him on the board and as the first person to occupy the chair for the inaugural session. The second person, the dignitary who is going to join as in the inaugural function is none other than our Dean of Indian College of Physicians, Dr. Shashank Joshi. Dr. Shashank Joshi will be joining the dais for the inaugural program. The third in the line is, of course, our chief guest, Dr. R.K. Agrawal. I would like to invite him to join the dais. Namaskar, sir. And of course, fourth in the line is none other than Mr. Sunil Mehra. He is the general manager of Abbott. Welcome, sir. Now, with these distinguished guests who have joined here in the inaugural program, first of all, I would like to introduce our Honorable President of Association of Physicians of India, Dr. S. Arul Raj. He has occupied the chair for the last almost 1 year as the president, and I am really very privileged to work with him, and I know him for the last more than 20 years. When I organized the Epicon in Greater Noida in way back in 2009. Well, Dr. S. Arul Raj, he needs no introduction. But as a customary, I would like to give his brief introduction. He was a gold medalist winner in MD Internal Medicine from the university from where he passed out. He has won many awards in cardiology and medicine in the national and international levels. He addressed a number of scientific forums in India and abroad. He has delivered many prestigious orations throughout India, and he is a very, very active member on all the forums which are concerned to the medical fraternity, whether it is a physicians forum or it is a Indian Medical Associations forum. I receive so many mails that he sends to the authorities, to health departments, to the government of India, for the welfare of the clinicians throughout the country. He is he has worked closely with National Board of Examinations and Medical Council of India. He is an emeritus editor of General Medical Guide, meant for the practicing physicians of India, and the family doctors, meant for the family physicians. Now, with this brief introduction, I would like to invite our Honorable President, Dr. S. Arul Raj, to deliver his presidential address. Dr. Arul Raj, please.
Thank you, Dr. Soni, for the nice words said about me. We all know that Soni is a great leader in API, and we are too happy to have him as an anchor today. I joined Soni in welcoming the chief guest of today's evening, Dr. R.K. Agarwal, Director of JIPMER, and our Honorable Dean, Dr. Shashank Joshi, and our Sunil Mehra from Abbots, and the two faculties, Chetan Bhatt and Sujit Chowdhury and Jyotishman, as well as all the delegates who have come to participate in this API dais. Friends, all of us know API is science. API always grows science. It supports an evidence-based medicine with an excellent clinical application. All of us are aware the end point for knowledge is application on the patients. That is the concern of API. And if you see everywhere, very great science is there. Lot of evidence base is there. Lot of research base is there. But how to apply it on the patient is also stressed. That is a special feature of medicine which is being promoted by API. And API is always associated with a lot of scientific programs. API is a scientific body. All of us know. At this juncture, I should recognize the unstinted support by Abbott to the scientific activities of APICON over 2 decades. This API DIAS came into force in the year 2013. Those years it was a physical meeting, face-to-face meeting. Nearly 30,000 physicians throughout the country have been reached over 3 years. Now, after some time, we wanted to bring it back. And the blessings of Corona, there are so many curses or grievances on Corona. But one of the blessings of Corona is we have become digital today. Today I'm able to see Dr. Soni face to face. I'm able to see Dr. Chetan Bhatt and Dr. Chowdhury. This is an advantage. Now today it's a digital era, thanks to our Honorable Prime Minister of our great nation, who is very much fond of digital India, who has digitalized the medical education and healthcare, and which we have thanked him adequately for legalizing telemedicine. During my first teleconversation with him, we made a request on behalf of API. The very next day, the barrier from the Mumbai High Court was removed and it was made legal. Today, we are all here on a digital CME. API DIAS digitally, reaching the unreached. Great advantages. We are all sitting now. I am sitting in the top of a hill in the southern part of the country, wherein I was only worried about the Wi-Fi. It has come well, now I am able to participate here. Like that, the learning, the teaching, healthcare offering, all does not have any boundaries to the most unreached person or in the remotest corner of this great nation. We will be able to reach. You will all be very happy. For the past 4 meetings, API DIAS has crossed the boundaries of India. We have crossed India, and API DIAS is being attended by all the physicians in Southeast Asia, CRO region of WHO. I am confident with the continued push, this API DIAS will become global, and that is my wish. And today we have a excellent dignitary, Dr. R.K. Agarwal, and API thanks him profusely for sparing his time to be the chief guest and share his knowledge and wisdom to us. To the topic today is, you have all seen the invitation. It is a concerned with gastroenterology. One is an IBS, which is an irritable bowel syndrome, one of the commonest problems and how to differentiate it, how to differentiate it from IBD, how to treat, all this will be, highlighted to us. And another thing is a NAFLD, which now it has metamorphosed into MAFLD. We have excellent gastroenterology physicians of this country who will be highlighting that. I am sure this API DIAS, digital webinar on various aspects of gastroenterology clinical problems will, highlight the knowledge and skills of our participating physicians, and ultimately the care they offer to the suffering in the society will definitely be upscaled. With these few words, I wish this digital conclave a great success, and I welcome our past president and dean, Dr. Muruganathan, who is a great thinker who conceptualized the API DIAS. Today he is here to participate with us. With this, I wish this webinar very great success. Thank you. Thank you all, ladies and gentlemen.
Thank you. Thank you very much, our Honorable President. And with this, I would like to welcome Dr. Muruganathan also, who has joined. Very good evening, sir. Well, after this presidential address, I would like to invite our Dean, Indian College of Physicians, none other than Professor Shashank Joshi. Dr. Shashank Joshi, he needs no introduction in the physicians forum. I call him as a dynamite of knowledge. He is a wonderful person with a bubbling knowledge, updated and very well known, not only in our country, but all over the world. He is a consultant endocrinologist and metabolic physician in Lilavati Hospital and Research Center, Mumbai. He is the chair of International Diabetic Forum, Southeast Asia region, and Dean of Indian College of Physicians. Dr. Joshi is fellow of several medical societies. He has received more than 200 awards. He was awarded the International Clinician of the Year Award by the American College of Endocrinology in 2012 and Padma Shri by the Government of India in 2014. Now, if I go through his biodata and the achievements, probably the whole evening I'll be speaking on this. But I would like to stop here and would like to welcome the Dean, ICP, Dr. Joshi, for his address. Dr. Shashank Joshi, please.
You see, it gives me a great pleasure that the academic wing of API is the Indian College of Physicians, and Dr. Arul Raj has taken and continued this API DIAS program, which used to be a physical program, which used to go to almost 80, 90 cities, towns, and parts of India to do skill building, capacity building. He has converted this whole knowledge dissemination exercise into a digital platform. The two main thirst areas which I want to talk is, one is the telehealth and telemedicine, which he very nicely said that today is the era to adapt and learn skills. We need to use technology right up to artificial intelligence in its best way. And second key is the patient to physician communication also is going to use the same telemedium. And therefore today the key is, the word is the tele. But at the same time, we should not get digitally intoxicated. And I always say in all my programs that you should do a 2-hour digital detox every day. At the onset, I really congratulate Dr. Arul Raj for wonderfully crafting this program, and my very close brother, Dr. Mangesh Tivaskar, very astute Secretary General of Association of Physicians of India, with the help of our team Abbott. Let me tell you something about team Abbott. They have virtually had no influence on this program. This is a completely unrestricted grant from them, and they have allowed us to take topics which are useful for the practicing physician and the clinicians, so that they can not only learn but whatever they learn, they can adapt it into their day-to-day practices. And that is so critical and vital in today's times. Also, what is useful is that we need to recognize that healthcare is soon going to get digital, and it is going to become a interactive digital platform, and which is what we are using today. And that is something which is very, very pertinent in the today's era. We also would like to make an effort to capture your feedback and translate it. But the whole aim, as Dr. Arul Raj very nightly said, is that we need to ensure that what you listen, you learn, what you learn, you adapt. And I hope that the various pearls of wisdom in different domains of medicine, which will be spanned over this year, you will learn digitally. And actually, this outreach, which Dr. Arul Raj said, is actually going to reach out to many more people. I was the second president to continue this API DIAS program, but we could reach a finite number. But now with digital health, we can not only reach within India, but outside India. And I would request everyone to make this program into a larger domain so that more and more people can listen, learn, and adapt.
Dr. Shashank Joshi, our Dean ICP, he gave to this DIAS program. I must admit that with the help of Abbott, with the initiation of this program API DIAS by Dr. Muruganathan and carried forward by all the stalwarts at the API presidents who were there on the chair after him, they took this program to a larger heights, and today this program is being shared by the clinicians even outside India, in Maldives, in Sri Lanka, in Bangladesh, and in other neighboring countries. And that is a very, very prestigious and very good achievement which we have done in this program of API DIAS. Now, next in line, I would like to invite our chief guest, Dr. Rakesh Agrawal. Dr. Rakesh Agrawal, he has joined as the director of Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry, on January 1st, 2019. And before that, he was in Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow, where he was there from 1991 as a faculty member of gastroenterology and worked in the various capacities, including the professor, till 2018, and then he joined the JIPMER prestigious institute in Puducherry. Dr. Agrawal, he is an eminent physician, teacher, and researcher. He has been involved in the research on clinical subjects, epidemiology, laboratory, and economic aspects of various subjects, various hepatitis even. He is also interested in vaccination, epidemiology, biostatics, research methodology, and many other areas. He is an elected fellow of Indian Academy of Sciences, Indian National Science Academy, National Academy of Services of Sciences, as well as National Academy of Medical Sciences, India. He serves as several national and international panels and committees and is an editor of a major international gastroenterology journal. With these few words, I would like to invite our chief guest of tonight, Dr. Rakesh Agrawal, for his deliberation. Dr. Agrawal, please.
Raj and Dr. Joshi for asking me to be with you. Sessions such as this, or what I can call continuing medical education, are extremely important. In the words of Dr. Charles Sidney Burwell, who was the Dean of Harvard Medical School from 1935 to 1949, who said to a class of students who had just joined, half of what we would teach you in the next 5 years will finally be proven to be wrong and half would be proven right. and we do not know which half would be proven right and which half would be proven wrong. So what we learn in medical school is not necessarily what we practice. Things change over time. Today with coronavirus infection, none of us learned anything about this in our medical schools, or even those who left medical school very recently. So sessions such as this, which try to give people updated information about diseases that were previously known, or about diseases which did not exist till some time ago, are extremely important. And to that extent, I must compliment the Association of Physicians of India for their initiative in providing this education to their members and to the physician community at large. But while doing this, we have certain responsibilities. We need to be sure that the information that is being given is evidence-based, is based on data, and also takes into account the cost effectiveness, something that's extremely important, particularly in countries such as ours, where the economic level of a lot of our patients is relatively low. So the treatments we are going to prescribe, the treatments we are going to recommend, the treatments we are going to talk to people about must be those that have been shown in randomized controlled trials or by using some other reliable method to be effective, to be and are cost effective, and that is what we need to do. The topics chosen for today: irritable bowel syndrome and non-alcoholic fatty liver disease. All of us know that these are extremely important topics because of the frequency with which these conditions are seen. They are diseases affecting the GI tract and the liver, which are extremely common, affecting 25 to 30% of general population in some areas. And to that extent, these are important. Also, these are diseases where all treatments have a relatively modest efficacy in randomized controlled trials. So it becomes important to look at expert opinion while keeping in mind the principles that I said a little while ago. Also, we need to be sure that the things that we talk about are not based on commercial interests, and I'm sure our speakers will keep that in mind because they being expert speakers, they would keep that in mind. With that, I would stop here and congratulate again the Association of Physicians of India and its leadership for running such training programs for their members. Thank you. Good night.
Thank you very much, sir, for your kind words for all my colleagues. And of course, these are very encouraging words which you have spoken to. I am really thankful for all your blessings and advice. Now, with this, next in line, I would like to call upon Mr. Sunil Mehra. Mr. Sunil Mehra, he is a general manager in Abbott. He is an experienced and seasoned commercial leader for the last 25 years in the industry of pharmaceuticals. And he has got the experience across marketing, research and development, innovation, and general management in consumers and companies. Although he started with Ranbaxy Research Lab in their R&D and worked there for 2.5 years, and then joined GlaxoSmithKline Consumer Healthcare and worked there for 23 years for research and development, for sales and marketing, and general manager for Sri Lanka and Maldives, even for 6 years. He joined Abbott Rapid Diagnostic as GM for India on 30th June, and he has got the educational background of B Pharmacy and M Pharmaceutical Sciences from BITS Pilani, MBA from FMS University of Delhi. And with these few words, I would like to invite Mr. Sunil Mehra for his deliberation and little introduction about the Abbott company as such. Mr. Mehra, please.
A very good evening to everyone. And thank you so much, Dr. Soni, for your lovely introduction. I would also like to thank Dr. Arul Raj, the president of API, Dr. Shashank Joshi, the dean for ICP, the API Association for a wonderful collaboration over the last so many years. Our chief guest for today, Dr. R.K. Agarwal, Director JIPMER, and our faculty members, Dr. Chetan Bhatt, Dr. Sujit Chaudhary, and Dr. Muruganathan, who started this collaboration in 2013. Over the next few minutes, I would like to share an overview about Abbott. Can I have the next slide, please? Next slide, please. Abbott is a global healthcare leader that helps people live more fully across stages of life. We are over 100,000 people across the world, and we haven't been in business for the last 130 odd years. In fact, we serve people across 160 countries with a wide range of technologies across, and we're business leaders in medical devices, diagnostics, nutritionals, and branded generic medicines in emerging markets, and have sales of excess of $30 billion. Next slide, please. Abbott's fundamental goal is to help people live fuller, healthier lives, maximizing their potential at all ages and stages of life. Our medical devices use technologies to keep hearts healthy, to help treat chronic pain and movement disorders, and to give people with diabetes better insights with more freedom and less pain. Our nutritional products help and build nutrition and immunity from infancy to adulthood. Our diagnostics provide more information to guide people to make effective treatment decisions. And our branded generic medicines in emerging markets help people get and stay healthy with quality medicines that they can trust. Next slide, please. We actually have market leading positions in all of these businesses. In cardiovascular, we are number one in remote heart failure monitoring, stents, valve repair, and heart pumps. We are also number one in diabetes care and continuous glucose monitoring. We are number one in chronic pain devices, point of care testing, and blood and plasma screening. In the nutrition portfolio, we are actually number one in adult nutrition and in pediatric nutrition in the US. And in branded generic medicines, we are number one in treatment of pancreatic enzyme deficiency, progesterone hormone therapy, and vertigo. Next slide, please. Abbott is also a world leader in medical devices. We have a broad portfolio of advanced healthcare technologies that are faster, more effective, and less invasive. Our connected care and digital health tools, from mobile platforms to wireless implants or wearable sensors, they're helping people and doctors make better, faster, and more informed decisions about their health in ways that fit very easily into their lives. Next slide, please. In diabetes care, Abbott's focus is to provide accurate results faster and with greater convenience so that doctors can monitor glucose levels with minimal pain or disruption. We are number one with more than 12 million users. Our next generation sensing technology, the Freestyle Libre, is a life-changing innovation that it eliminates routine painful finger sticks to draw blood. It provides actionable insights and improved outcomes. As well, it's affordable and accessible to millions of people with diabetes and currently present in 50 countries across the world. We also have digital tools that help record and monitor trends over a smartphone app that can be shared with caregivers remotely. Next slide, please. We are very committed to bringing the benefits of our trusted medicines to more people in the world's fastest growing countries. We offer a broad portfolio of medicines in key therapeutic areas such as gastroenterology, women's health, cardiometabolic, pain management, CNS, and respiratory. In fact, this diverse portfolio also includes the world's medicines for treatment of pancreatic enzyme deficiency, progesterone hormone therapy, as well as vertigo treatment. Next slide. In fact, every day, more than 18 million people in the world use our products in some way or the other. We also compete with pure generics by providing a very differentiated offering, by having high quality standards, a very reliable supply chain, superior clinical science, and patient-centric innovation. In fact, a lot of our innovations and product portfolios focus on what are region-specific needs depending on the health need in that particular region or that particular market. Next slide, please. Now, coming specifically to India, like we said, we've been available around the world for the last 130 years with presence in 160 countries. In India, we have been around for the last 110 years. In fact, we are one of the few MNCs who have manufacturing plants in India in 3 different locations in Himachal, Gujarat, as well as Goa. And we have a state-of-the-art R&D center with 100 plus researchers in Mumbai. With this, we actually help, we are pretty active in pharmaceuticals and branded generic medicines, our nutritional products, which help and maintain health from infancy to adulthood, in medical devices in cardiovascular care and diabetes care, and in diagnostics across lab to point of care, molecular or rapid diagnostics. Next slide, please. Abbott has pioneered innovative ways to screen, diagnose, and monitor a vast range of health conditions with great impact on speed, accuracy, and efficiency. We are, in fact, market leaders in advanced instrument systems and lab-based tests for hospitals, reference labs, blood banks, screening, as well as disease diagnostics. We are also the market leaders in molecular diagnostics for managing infectious diseases and serious illness, patient-side diagnostics for lab quality results. And we have sophisticated information solutions that help transmit this data remotely to caregivers to take more informed decisions. Not only this, in recent times in this pandemic, Abbott has been the front runner in delivering and developing close to 9 tests which have been approved by US FDA to test and screen the COVID virus, whether it's the virus itself or antibodies for the virus. Next slide, please. And as we do all this and try to make a meaningful difference, we obviously got our share of recognition, accolades, and awards across the world. We are one of those few Fortune 500 companies, most admired companies since 1984. And we're the #1 medical products for the last 7 years. We are also one of Fortune's best big companies to work for. In fact, we are one of the best places to work in the 25 odd countries and many more such accolades over the last few years. Next slide, please. Abbott's been helping people live more fully for more than 130 years. We are very proud of a long history of success, but we're constantly looking at the future, seeking newer and better ways to help people live their best and fullest lives. We are strong, focused, and ready for the future. On behalf of Abbott, I would like to once again thank API for partnering with thought leaders in this space and sharing information through the use of digital means. I would also like to thank all members of the medical community for what you've been doing at the front line of this crisis. Wish you all the very best and have a great evening. Thank you so much.
Well, thank you very much, Mr. Mehra, for your nice words and giving a brief about this company, which, of course, we as a clinicians are also proud of. Well, with this, we finish our inauguration, and we move on to our scientific program for tonight. And to take you through the scientific program, I would like to invite a very dynamic person and very close friend of mine, none other than Dr. A. Muruganathan. Dr. Muruganathan, he is at present the governor of American College of Physicians, India chapter. I call him with a nickname which I am not going to disclose tonight, because this is between me and him, that what I call him, and he must be remembering that also. But then if I go through his biodata and the introduction, I would like to call him as President Emeritus, because he has got that knack of becoming the president so often of so many prestigious organizations. He was the president of Association of Physicians of India. He was the president of Hypertension Society of India. He was the president of IMA. He is the president of IMA Tamil Nadu State Branch. So in fact, he is the President Emeritus for me and for many of our colleagues in Association of Physicians of India in Physicians Forum. He has been the dean also of Indian College of Physicians. He is the Rotary past president governor, and he was the vice president of Indian Red Cross Society, and he is the chairman of 60 AG Hospital. So what not? All, a big all-rounder and wonderful personality, very infectious, who will charm you with his personality once you come in contact to him. Dr. Muruganathan, now the stage is for you to take us through the scientific program tonight. Dr. Muruganathan, please.
Thank you, Dr. Soni, for that excellent, nice words about me. I always cherish your association and your friendship, and I'm very happy to see this API DIAS is growing day by day, and a lot of people are benefited not only in our country, even the other countries internationally. It is going well. So, without wasting much time, today we have got two eminent speakers. The first speaker, Dr. Chetan Bhatt, is the head of department and consultant in the Department of Gastroenterology at Sir H.N. Reliance Foundation Hospital and Research Center. He is the chairperson of IBS Task Force of Indian Society of Gastroenterology. He is also a core committee member of IBD Research Group and Task Force of Crohn's and Colitis Foundation of India. He has vast teaching experience and has developed an innovative and novel concept of extensive medical teaching for undergraduate and postgraduate students over 3 decades. Dr. Chetan has several publications and presentations to his credit in the area of gastroenterology and has authored chapters in API Textbook of Medicine and has been the faculty member of International and National Conference of IBD and Gastroenterology over the past several years. With this introduction, I would now request Dr. Chetan Bhatt to give his presentation. I thank Professor Arul Raj and N.K. Soni, the chief guest, and also Vin Mehra for our nice program. Thank you. Over to you, Chetan. Chetan, please unmute. Chetan, please unmute.
Yeah. My screen share is not coming. 1 minute.
Yeah, it's coming now.
It's coming now? Okay.
I could see the last slide.
Yes.
No, I understand. Always IBS means, it will come fast.
Thank you very much. At the outset, let me thank everyone. Good evening to everyone. I would like to thank our President API, Dr. Arun Raj, our Dean, Dr. Sasank Joshi, today's anchor, Dr. N.K. Soni, and today's moderator, Dr. Muruganathan. And also, I'd like to thank Mr. Sunil Mehra, GM India About Rapid Diagnostic, Dr. S. Das, Medical Director About India Limited, and Dr. Bala Gopal Nair, Regional Medical Director About EPD India. Now, IBS is a very simple topic, but the problem with IBS is that everyone thinks IBS is very simple, but on average, about patient visits 3 doctors over 3 years before he is labeled as IBS. Almost 60% doctors in a practice say IBS is very easy to diagnose, but only 20% doctors are familiar with the guidelines for the IBS. 80% physicians do not use guidelines. They use the clinical instinct to diagnose and treat IBS people. Now, what is the problem with IBS patients? It's about stool frequency. Stool frequency is different in the Asian populations and American and European populations. Like China has on average 7.1 bowel movements per week. Iran has 12.5 per week for the men and 14 for the woman. Whereas in India, we have 7 to 14 bowel movements per week in about 99% of cases. In India, it is higher bowel movement frequency compared to the Western populations. But whenever you talk about the bowel movements and perception of bowel pattern, you must ask patient to describe what is his feeling about the bowel movement. So on average, in India, average person passes about 1.5 to 2 stools per day. Stool weight in less than 15 years is about 370 grams, whereas more than 50 years is about 300 grams. On average, Western people have about 3 stools per week, and on average weight in India is about 200 grams of defecation volume. What is not defined in a word IBS, whether it's a Rome 1, Rome 2, Rome 3 or Rome 4, there's an incomplete evacuation. That is what Indian people describe. They say, the doctor, we are not satisfied with our bowel movement. Now, when they say we are not happy and satisfied with bowel movement, when you ask them, the stool is not very hard, is not very soft, it is varying in consistency every day. Straining is present. So straining and incomplete bowel movement is a very main important part of the Indian IBS, which has not been described in the world or any other world literature. It is described. Person goes to toilet second time or third time just to relieve the abdominal distension and heaviness, and also to make sure that he clears his bowel. Number of stools are variable every day. He may pass 1 stool or maybe 2 or maybe 3. It depends upon what diet he has taken in last few days. What is the difference between the Indian IBS and the Western IBS is that in India, almost 99% will have at least 1 bowel movement per day, and it is mainly related to the high fiber diet and a faster gut transit. Whereas the Western people have 3 bowel movements per week. Now, this is a very famous Bristol stool chart, and this Bristol stool chart is type 1 is a very hard, small, pellet-like stool. Number 2, 3 are still constipated stool. Number 4 is an ideal smooth like a toothpaste coming in a one-go stool. And then you have a softer stool. So 5, 6 and 7 are a softer or a diarrheal stools. Number 4 is a good stool, and 1 and 2 are constipated stools in the Bristol chart. So if you see, you divide the stool pattern as per the more than 25% of the bowel movements every day. If the more than 25% is basically hard stool, that is 1 and 2, you call it IBS-C. If it is more of a 5, 6 and 7, mainly 6 and 7, you call it a IBS diarrheal variety. If it is varying between type 1 to type 6, you call it a IBS mixed variety or alternating variety. But if person is not been able to answer very well and cannot say stool pattern, we say unspecified. So based on the stool frequency and the percentage of the stool the person passes, if it's more than 25% hard lumpy stool and less than 25% loose watery stool, then you call it IBS-C. Because in IBS-D, more than 25% of time is a loose or watery stool, and less than 25% of time is a hard lumpy stool, you call it IBS-D. The mixed pattern, more than 25% hard stool and more than 25% loose or watery stool, you call it a mixed variety. An unspecified variety when a patient is not been able to declare very clearly number of stools and how he's passing the stool. What is most important? Which kind of IBS you are going to see in your practice. The mild variety, which is 40% of cases, moderate variety is about 35% of cases, and severe variety is about 25% of cases. What is most important here is abdominal pain is very mild or intermittent in a mild variety, whereas in the severe variety is a very frequent and severe or constant pain in the severe variety. Number of other symptoms, that means besides the GI symptoms, the bowel symptoms, the other system involvement symptoms, like for example, migraine headache or fibromyalgia or neck pain, back pain, urinary symptoms, chest pain, all these symptoms are less in the mild variety, about 1 to 3 Moderate variety is 4 to 6, and more than 7 or 7 in a severe variety. Quality of life is good in mild variety, whereas poor in severe variety. The visit to the doctor is less for the mild varieties, about 1 per year, whereas moderate variety is 2 to 4 per year, and severe variety visit to a consultant is more than 5 per year. Activity is not restricted in mild variety, or it may be maritime restricted in a severe variety. Work disability is more than 10% in severe variety, where the work disability is not present in mild variety or less than 5% of cases. What is also important in a mild, moderate, severe variety, that is basically a psychological factor and a physiological factors. There are very minimal psychological factors in a mild variety, or if they are there, patient is aware of. For example, somebody is losing the job, or a daughter's engagement gets cancelled, or a child is not well, or somebody died in a family. They are aware of the fact that there is stress in a family or in a immediate relations, and they disclose it to the doctors. In moderate variety, they have underlying psychiatric trait or a personality trait. They are not aware of the personality trait, and they also have a physical stresses and mental stresses, and they may not disclose every time. Whereas in a severe variety, is a very high psychosocial distress, and there is a drug abuse history also, and there is a history of somatizations also. In a milder variety, all over the world, men are affected more than women or equal to women, but in a moderate to severe variety, woman is more affected than men. Age group wise, mild and moderate is seen in a middle-aged and younger person, less in younger person. A severe variety is seen more in a younger person or a middle-aged person. What is most important, you see, IBS patient is not to miss the organic disease. Every physician is dreaded, especially every gastroenterologist, when he is labeling patient as IBS, or when he writes the IBS treatment for any patient with abdominal pain or a GI symptoms, he is worried that am I not missing any organic disease? And what is most important that time is the red flag signs. If the person is more than 50 years, first time presenting as a symptoms, don't diagnose IBS. There's a recent change in bowel habits, which was not there before. Then you think of newer disease or a symptom setting in. The patient is bleeding like melena or hematochezia, definitely it's not IBS. If there is a nocturnal pain or a nocturnal passage of the stool, patient has to get up at night time to pass stool, definitely don't think of IBS. If there is an unintentional weight loss, patient says that I'm not dieting, but still I lost 5 to 10 kg. There's more than 10% of last recorded body weight. Then you consider it as a non-IBS cases. If there's a family history of colorectal cancer or inflammatory bowel disease or any organic disease, don't try to diagnose IBS at the first time. If you can palpate any lump in abdomen or a lymphadenopathy, definitely don't think of IBS. If there's iron deficiency anemia or fecal occult blood is positive, think twice before you label it as IBS. And most importantly, if the person has got a fever or rise in WBC count or very high ESR, don't try to diagnose IBS. If you suspect IBS clinically, but if the patient's ESR is more than 100, don't think that is IBS, or hemoglobin less than 5 grams or WBC count more than 15,000, don't try to diagnose IBS. Now, IBS there are various pathogenetic factors for the IBS. Till today, the Rome 1 or Rome 4, or now we are getting into Rome 5 criteria. There is no definite etiological factors. Right from the earlier we used to say brain-gut axis. We have changed that to now gut-brain axis. Now we say the immune system dysregulations, genetic predisposition. People say that IBS parents produce IBS children. Environmental problems, change in brain-gut activity, change in the GI motility, change in the visceral perception of the pain, altered gut microbiota, psychosocial dysfunctions, they all produce IBS, they all lead to IBS. What is more important, I was telling you, is a small bowel overgrowth, bacterial overgrowth. Now the small bowel bacterial overgrowth is very now closely associated with the symptoms of the IBS. Normally, bacterial colony count is more than 10⁻³ Some use 10⁻⁵ in a duodenal or jejunal aspirate. And mainly it's a coliform bacteria, gram-negative aerobic and anaerobic bacteria. The risk factors for SIBO, that is small bowel intestinal bacterial overgrowth, a structure abnormality of the GI tract or a gut dysmotility. And other responsible factors are metabolic disorders, elderly persons, sometimes antibiotics, PPI, organ dysfunctions, even an irritable bowel syndrome may link to the SIBO. The frequency of SIBO in Uday Ghosal's study in India is roughly around 13% of Indian IBS is associated with SIBO in India. Now, what is most important here is if you do testing of GI tract for the SIBO in a healthy patients and IBS patients, almost 23% people in upper gut aspirate culture will have positive for SIBO in IBS patients, whereas in a normal healthy patients about 1%. On a glucose hydrogen breath test, 26% may be diagnosed as SIBO in IBS, whereas only 5% cases in healthy subjects. And on a lactulose hydrogen breath test, almost 45% can be labeled as SIBO, whereas in a healthy person is about 20% cases. What is the pathogenesis? Is abnormality in a salivary IgA, gastric acids, duodenal bile, abnormal GI motility, secretory IgA, and ileocecal wall dysfunctions. And the factors associated with SIBO mainly seen in the female genders, elderly person, diarrheal variety of IBS, or post-infectious IBS, or PPI or narcotic drugs, and low hemoglobin. So what is the treatment of SIBO for IBS and SIBO? Is rifaximin about 1200 to 1600 milligram per day for 7 to 10 days. And you may use probiotic. Probiotic role is always questionable in IBS, IBD. There are few studies that say probiotics are useful, but various studies have not demonstrated the role of probiotics. But at any given time, we may use, probiotic if there are symptoms like bloating or a loose stools or a watery stools. That time probiotic may be useful. And what is also useful that time is the dietary modifications, avoiding milk and dairy products, or avoiding allergic food. Prokinetic drugs may be useful in a patient with a low GI motility or hypomotility. Fecal microbiota transplant in extreme cases may be done. If you treat SIBO in IBS cases, you must have seen many times. In the olden time, we used to use doxycycline, or before that, we used to use neomycin. Neomycin used to give good results in a gas, bloat, and diarrheal variety. Then doxycycline. Now rifaximin gives a significant improvement in SIBO treatment. But what is important here, that treatment with rifaximin does not cure the IBS. It temporarily improves the symptoms of IBS for 3 to 9 months, but patient may get recurrence of SIBO or IBS symptoms. What is another important point in IBS is not to miss the gluten sensitivity. The gluten disease and gluten sensitivity. In one of the study in India, almost 6.1% people of 362 IBS cases were tested positive for anti-TTG antibody, and almost 28 to 30% people were positive for anti-gliadin antibody. Now, this may not be celiac disease, it may be gluten sensitivity. So what is more important over here is a non-celiac gluten sensitivity. There is a very possible overlap between a gluten-related disorders and IBS symptom. The FODMAP diet is very important now in IBS cases. The low FODMAP diet improves the symptoms of IBS cases, and that has become now a very popular in a very severe resistant IBS cases. So when you treat IBS cases which are resistant and not responding to your treatment, will you please have a look at gluten sensitivity, not the celiac disease, but a non-celiac gluten sensitivity. And stopping the gluten or restricting gluten may improve the IBS symptoms. There is a now fad in USA to go on a gluten-free diet. Everybody need not go on a gluten-free diet. Only if you demonstrate that it is helping the patient, then only you should advise gluten-free diet. And before you advise gluten-free diet, you do the celiac serology test. And if the celiac serology test is positive, you may do upper GI scopy for the duodenal villus biopsy to see the atrophy of the duodenal villus pattern. And if you find the abnormality there, put the patient on gluten-restricted diet. And if the patient is negative for the serology, you may give a trial of the gluten-restricted and FODMAP restricted diet, and see if the patient is better with that or not. So gluten is one of the most important part in treating resistant IBS, not each and every IBS cases. What is most important that IBS patients are associated with various other symptoms. For example, lethargy, urinary symptoms, bloating and early satiety, urgency of the stools, nausea, urge incontinence, dyspareunia, thigh pain, fibromyalgia, backache. It's a very big list. If you see the associated conditions with IBS, the fibromyalgia, interstitial cystitis, other urogenital symptoms, migraine-like headaches, psychiatric behavioral disorders, post-traumatic stress disorders, various abdominal surgeries, and previous enteric infection, that is post-infectious irritable bowel syndrome. So now this will label it as a neuroendocrine immune dysfunction syndrome. So IBS forms the part of this neuroendocrine immune dysfunction syndrome. We have fibromyalgia, chronic fatigue syndrome, your tension type headaches, migraine type headaches, primary dysmenorrhea, periodic limb movement disorders, your temporomandibular pain and dysfunction, restless leg syndrome, regional fibromyalgia, and facial pain. So all these symptoms and syndromes are associated with irritable bowel syndrome. What is most important is a fibromyalgia syndrome. Most of your resistant moderate to severe IBS cases will complain of pain at these different sites. And these are very typical sites. The cervical pain, they may have a very severe pain, neck pain, radiating type of pain in upper limb. Then you may think of cervical spondylosis, you may do cervical MRI. If the pain is radiating to the left hand, you may consider myocardial infarct, interscapular pain, or a lumbar backache. You may have to do multiple MRIs. Then you have knee pain, leads to multiple MRI of the knee joint. Why this is important? Because these are all fibromyalgia tender points, and most of the resistant severe IBS cases have. And what happens that with this kind of pain symptoms, and they mimic various disorders like pleurisy, gallbladder pain, or kidney stone pain, appendicular pain, or tubo-ovarian pain, or intestinal adhesions pain from the previous surgery, or female genitalia pain and dyspareunia, again pancreas pain or pain radiating to the back, pleurisy pain and a cardiac pain. All this pain leads to number of investigations, CT scans, MRIs, which can be avoided once you are confident and once you understand IBS. And if you see this kind of surgery, scars on the patient's abdomen, there's cholecystectomy done for the right hypochondriac pain, right iliac fossa pain, appendicectomy done, or a dysmenorrhea and a peronia and a lower abdominal pain hysterectomy done, then this patient has got a very poor prognosis. This is a very severe IBS cases with a somatization syndrome, and these are very difficult to treat in clinical medicine. So what happens, the fibromyalgia syndrome at one end, IBS in between, and panic disorders, major depressive disorders are at the other end, and you have atypical chest pain or a facial pain, migraine pain, IBS, chronic fatigue syndrome. These all form the affective spectrum disorder family, which leads to multiple investigations, multiple diagnoses, wrong treatment, or probably not correct modality of the treatment. So what is most important? If you see headache, not a migraine headache, migraine-like headache. That means the person has a headache which almost mimics a hemicranial headache, but there is absence of aura and there is absence of family history, and that there is no typical stimulating factors for the migraine-like headache. Almost 50% of IBS cases at some stage of disease will complain of severe headache compared to 3 to 29% of control group. In various studies, they have proven that migraine-like headache is very common in IBS cases. Second most important is the interstitial cystitis, that is all urogenital symptoms, chronic irritative bladder symptoms, burning in the urine, but urine examination is normal, 1 to 2 pus cells, and these symptoms are aggravated by the stress and the GI symptoms. You have a motor sensory bladder dysfunctions, you have positive cystoscopic finding in a chronic interstitial cystitis, you may have erythematous patch, linear scarring, ulcerations, petechial hemorrhagic spots, and if you take a biopsy, there will be increased mast cells, and they are very, very frequently associated with 50% of IBS cases. What we call it is a psychogenic bladder syndrome. What is psychogenic bladder syndrome? Is a chronic irritative urinary symptoms in absence of organic lesions in a cystoscopy. Urodynamic studies are normal, but on clinical history taking, there's a burning in the urine, burning in the urethra, severe lower abdominal pain, and this is called as a psychogenic IBS-Leiter syndrome. Then you have a very big group of depressive disorders, sleeping disorders, and IBS overlap syndrome. So what happens here that all these three are overlapping and all these three are interconnected and may have role to play. When you have a stress, GI microbiota also gets affected. The gut-brain axis and the microbiota play a very important role. In a stress, there's definitely intestinal dysbiosis, and with the IBS symptom, there is definitely documented intestinal dysbiosis, and there is a definitely behavior pattern of the person is different. Person may be irritated, person may have an emotional overlay, and this kind of stress is known. So what is important here, does the probiotic work every time you give probiotic? They have proven that if there is you've done a vagotomy in this kind of cases for the various gastric acidity disorders in the past, then the probiotic has no actions on this kind of cases. Now, what is most important, many IBS experts believe that the psychogenic factors are not so important in IBS and every IBS patients are not psychiatric cases. That's very true. The mild variety of IBS cases or those who are non-consultants, they have IBS symptoms, but they don't go to doctor. I was examining one patient of IBS. He said, Dr. Saab, I'm passing 3 to 4 stools every day and I'm very disturbed by that. His cousin brother had come with him and he started laughing. So I asked him, why are you laughing? He said, doctor is talking nonsense. I pass 7 stools and I have no problem. I got a toilet in my office. I got a toilet in my bedroom. I go many times. I have no problem. What's the point? I mean, complaining about passing increased frequency of stool. He had IBS, but he was not complaining. As a person with a 3 stool was complaining. So what is most important? Mild IBS variety have very minimal stress disorders. But as you go higher up and as you go to a specialty centers or a tertiary care centers, you have more and more patients with IBS symptoms. And why does this happen? I will tell you in the next slide. If you see in the primary, that is general practitioner, secondary is a consultant level, and tertiary is a referral gastroenterology center. The symptom severity is always very severe in the tertiary center. Symptom consistency is also very severe and persistent in a tertiary center. With a milder variety, going to the general practitioner, there is no symptom consistency. That means today is constipated, tomorrow after a few days he may have a little loose stool because of eating food outside, and he may recognize stress that, oh, I had some problem in my family, I had a fight in my family, so my stomach was upset. And as a severe patients, they refuse to accept that I have a psychiatric problem. And they in fact say that, doctor, don't tell me that all my bowel problems are in my head. I don't like that people call me psychiatric cases. That means they have very severe psychiatric disorders, but they are not willing to accept it. So what happens? The IBS patients have psychosocial comorbidities. The social stress, there were environmental experiences from the childhood adversities, the recent life events, there is something happening in their life, the chronic social stress, or they have personality trait. They have anxious personality trait, they have depressive personality trait, or they have neurotic personality trait. Abnormal illness behavior, they have treatment seeking behavior, illness attitude, they go and talk about the illness to everyone, or they have somatization. Every time they have symptoms, they get a headache, they get a body ache, they get a knee pain or abdominal pain, or a psychiatric disorders, in a very severe resistant cases, that is the generalized anxiety disorders or major depressive disorders or panic attack that you see in a very severe IBS cases, where the social stress and illness behavior or personality you see in a milder variety. So what happens, almost in a very severe tertiary center with the severe IBS, almost 70 to 80% cases will have one psychiatric comorbidity compared to the controls. Major depressive disorders are very common, somatiform disorders are very common, and panic disorders are also there on the card. So depressive disorders, major depressive disorders, anxiety disorders, panic disorders, and somatization is very common in IBS cases, Indian IBS cases, and almost 60 to 65% of Indian IBS cases may have one psychological problem they have. But if you have a somatization disorders, which is the most difficult part, if they say that I've got a severe pain in my back or my neck or headache and I'm not better, these are very difficult cases to treat in practice. So in one study of retrospective analysis of 6 studies, almost 2 lakh cases and 1,77,000 IBS cases, the very, very high incidence of psychiatric comorbidities, almost in a tune of 65% of cases. In one of the Indian study from the northern India, almost 80% of cases had psychiatric comorbidity in moderate to severe cases compared to the 40 cases on a 40% in the control cases. Now, looking at all these associated conditions, that is fibromyalgia, backache, headache, neck pain, abdominal pain, knee pain, how does it affect your treatment? It is very important to identify the extra GI symptoms of the IBS cases and also treat them. At least do one-time investigation, make patient comfortable that, okay, I have investigated your knee pain or a neck pain or a chest pain. I've done ECG, it is normal. I've done your 2D echo or one stress test, you are normal, so don't worry. After you do that, you identify his dietary problem, modify his diet, try to go on a low FODMAP diet, avoid gas-producing foods, Preferably, if you can go on a gluten-free diet or a gluten-restricted diet, try to do that. Go on a dairy-free diet. Don't go on increase fiber in every case because fiber sometimes worsens the pain and bloating. So don't use fiber in every cases. Only indicated cases you use. Soluble fiber is always better for even a constipation. It is better. Elimination diet, that means if you are sure that this patient is allergic to certain foods, you do certain investigations like food intolerance test and find out certain diet which are allergic and you avoid those diets. Lifestyle modification is very important, physical activity and exercise is very important. Psychological behavioral therapy, gut-directed hypnotherapy, multi-component therapy is very important in the moderate to severe cases. Milder cases, just physical examination and reassurance by the treating doctor is more than enough most of the time. Pharmacological treatment for the entire IBS is beyond the scope of my talk today. Drugs for the IBS-C or IBS-D, drugs for the pain and anxiety disorders is little bit out of the today's discussion because it's a very big topic by itself. But I would tell you that most of the Indian people fall into the mixed variety or alternating variety. What happens that they have a diarrhea at one time and they may have a little heart stool and straining at one time. So these kind of cases are very important. So diarrheal variety, you treat with the loperamide and similar other drugs. Constipated variety, fibers, plenty of water, soluble fibers, go for the newer drugs which is available in the market, sodium picosulfate and procalopride you can give. But if these people have, along with the diarrhea or along with the constipation, they have pain, don't use other prokinetic drug, use calcium channel antagonist and that will be very useful. A gut-specific calcium channel antagonist, that is mebaverine hydrochloride, will be very useful for your treatment. So if you see the drug list of the IBS management, it's a very big drug list for the IBS management. And IBS-M, that is mixed variety, IBS-D is a diarrheal variety, IBS-C is a constipated variety. So we have a various drug to help you on all the cases and also the psychotropic drugs to help you in every cases. What is important is a high FODMAP diet versus a low FODMAP diet. So this list is very important. You can download this list from the internet or you can go on the internet FODMAP diet and you can download this list and you can make a list or various people have made a pictorial list also of the high FODMAP and low FODMAP diet. Those who cannot read English or they are illiterate people, you can give a pictorial things to carry and you can make them understand. But what is most important is, you avoid garlic, onions, watermelons, milk, legumes, wheat, high fructose, high corn fructose, and cashew nuts and pistachio. Low FODMAP diet is basically all the vegetables you have over here, certain fruits you have, almond milk, and certain non-veg items you have that you can download from the internet. What is important, I was talking about, is the mebaverine hydrochloride. Mebaverine hydrochloride is a very important role to play in IBS cases in India. If the person is saying that I'm straining at the stool and I'm passing 3 to 4 stools, it is very difficult for you to decide what to give. If you're straining at the stool, you would like to give prokinetic drug or you would like to give a procalopride or something. And if he's passing 5 to 6 stools, you would like to give a loperamide. So either way, you're making a mistake. So what is most important in this kind of cases, mebaverine hydrochloride is very important. The selective calcium channel antagonist for the colonic mucosa is very important. So it inhibits the contractile pathway of the gut and it is directly smooth muscle relaxant, but it is not like an antispasmodic drug, and it increases the colonic transit time. It's a very effective drug, and secret of my practice is mebaverine hydrochloride. I use it very selectively in a group of patients where it gives a maximum result. Now, what is important is that most of these cases have associated anxiety disorders. They may have anxiety or panic disorders, or they may have a underlying mild depression also. So that time, if you don't want to use a psychotropic drug, because what happens now, the people sitting outside your clinic, moment you write drug, they go outside and they check on internet, doctor, you've given me antidepressant drug, doctor, you've given me psychological drugs, I am not a psychiatrist. They come back and they argue with you. The chlordiazepoxide, along with the mebaverine, is a very good drug. Chlordiazepoxide gets attached to the benzodiazepine binding receptor sites, GABA receptors, and there is a very effective role to play. And the mebaverine, along with the chlordiazepoxide in IBS cases, has an antispasmodic, selective calcium channel antispasmodic effect, and also anti-anxiety effect. So it's a very good drug. It's approved by the FDC, and it's a very effective drug. I use it, very frequently in my practice, and gives me very effective results. So what is important in IBS cases? Each and every IBS case is a different case. Though no two IBS cases are same. When the same IBS cases presents differently over a period of time, you may need to change your treatment. What is the most important thing? You learn from your own experience, or you learn from the experienced person. Thank you very much, everyone. Thank you very much.
Thank you, Doctor, for that wonderful presentation. I will reserve the questions after the other speaker completes his talk. Now it is my pleasure to invite the next speaker. Can you stop sharing your slides? Yeah. Yes. Chetan, yes. Now the next speaker is Dr. Sujit Chowdhury. He is a senior consultant gastroenterologist at Omri Hospitals, Salt Lake, Kolkata, West Bengal. He has special interest in GI motility, and he was trained at Guy's Hospital and Medical School, London University, UK. He has been working on esophageal and anorectal manometry and esophageal pH studies for at least 25 years. He has also special interest on Helicobacter pylori infection, and he has been doing collaborative studies with ICMR, NICE, Kolkata, and SN Bose National Center for Basic Sciences, Salt Lake, Kolkata. He also has special interest on management of IBD, chronic hepatitis B and C infections, and NFLD. He has more than 25 publications in national and international journals. He is going to talk to us on an important subject, NFLD. Now I request Sujit Chowdhury to give his presentation. Over to Sujit. Thank you. Yeah, you will put stage back.
ஒண்ணுமே கேட்கல ஒரு பேசுறது கேட்கல அவர் பேசுறாரு பாரு
process and the management part. So I will speak on briefly about introduction, prevalence, risk factor, pathogenesis, but predominantly, as I mentioned, the diagnosis and the management. So the introduction, what is the magnitude of problem of this disorder, that is fatty liver disease? This is a real public health issue now. So the global prevalence is that is 1/4 of the whole world population is suffering from this problem of fatty liver disease. So there is high economic burden for treatment of this disorder, for diagnosis and treatment. And there is a problem, peculiar problem of lean NASH. I will highlight a few points on it, in particularly in Asia, that these persons who are not obese, they are having this fatty liver disease. And among the patients of fatty liver disease, there is a group that progresses to liver disease, that is called NASH, that is non-alcoholic steatohepatitis. And about 1/3 of the patients of hepatocellular carcinoma can occur in the background of NASH, and it is one of the important cause of hepatocellular carcinoma, both in Western country and also in our country also. So this is a real problem of fatty liver disease, and so the fat in the liver can be primary, that is non-alcoholic fatty liver disease, or really sometimes fat can accumulate in the liver secondary to other disorder. So it is our duty to diagnose, and whether there is a secondary cause of fatty liver like hepatitis C, some metabolic disorders, and some drugs can produce fatty liver disease also. So, but we discuss on our subject is on primarily, that is primary fatty liver disease, or that is non-alcoholic fatty liver disease. There are two phenotypes. One is the non-alcoholic fatty liver disease without liver damage, that is bland steatosis, and one the phenotype is called NASH, that is non-alcoholic steatohepatitis. And there is inflammation, and this inflammation in the form of ballooning of hepatocytes, hepatitis. What is the term called MFLD? M means metabolic disorders, that is metabolic disorders associated with fatty liver disease. The problem of NFLD, that always you have to think that you have to exclude alcohol when you are diagnosing non-alcoholic fatty liver disease. But sometimes there is some problem and there is cutoff, and there is but it is been found that NFLD is mostly associated with the metabolic disorders and particular obesity. I will describe later. Obesity and diabetes is most important. So for that is a consensus driven proposed nomenclature by these experts, and so this showed that the new definition that when there is hepatic steatosis, that irrespective of that whether there is alcohol or not, but if there is a significant alcohol, definitely you have to exclude alcoholic liver disease. They are either overweight or obese, or there may be non-overweight, as I mentioned, that is lean, or there is, and that there is, or they are diabetics, that is type 2 diabetes. And that there is few of the, at least 2 of the criteria, that is called metabolic risk abnormalities, like there is, that is the waist circumference, blood pressure, plasma triglyceride. So by all these factors, that disorder, that it is a patient is having the metabolic syndrome, and then if there is then it is called MFLD rather than NFLD. Maybe some problem. Okay. So, so this is what are the problems, and the non-alcoholic fatty liver disease can progress. I've already mentioned that can be complicated with non-alcoholic steatohepatitis, and when there is steatohepatitis, there is ongoing fibrosis, that is liver fibrosis, and when there is advanced fibrosis, that is called liver cirrhosis, and liver cirrhosis may be complicated with end-stage liver disease like decompensated cirrhosis or portal hypertension with its complication, or there may be associated complication of liver cancer. Rarely, the non-alcoholic steatohepatitis can progress to cancer without cirrhosis. So the natural history, about 90% of NFLD is a simple steatosis, and the prognosis is very good. There is no overall increase in the mortality compared to the general population. But approximately 10 to 30% of these NFLD progress to NASH, and about 20 to 30% of NASH progress to cirrhosis. So 1/3 progress to cirrhosis. And when as I mentioned that about there is a risk of hepatocellular carcinoma. So there is natural history of NFLD. When it is NASH, it is a progressive disease. And the steatosis, the global prevalence of NFLD is around 25%, I have mentioned, and the global prevalence of diabetes, obesity, and overweight, though is significant, which is associated with NFLD. And the NASH can progress in the tune of 25% over 7 to 8 years to cirrhosis, and 1/4 of them can progress to cirrhosis, can progress to decompensation. The most important factor for death, cause of death, is very important, that not, when the patient is having the non-alcoholic fatty liver disease, the cause of death is not due to primarily either liver disease and its complication, it is cardiovascular malignancy. So as a whole, with this population of non-alcoholic fatty liver disease, the mortality is high due to the cardiovascular disorder and extrahepatic malignancy, and then the hepatocellular disorder like cirrhosis and liver cancer. So cirrhosis or liver cancer and extrahepatic malignancy is the second common cause, but the first cause, the predominant cause of death in this group is cardiovascular. So it is our responsibility to identify, when you are dealing with a case of non-alcoholic fatty liver disease, whether there is cardiovascular disease or not, because all these metabolic factors, there is high risk of cardiovascular disorders. So the global prevalence is, I mentioned, but there is some difference in the different part. The highest prevalence is in the Middle East countries, and also in the South America. So relatively less in Africa. In India, the prevalence varies, it depends upon whether it is rural or urban areas. Average, it is around 30%, and it has been found that in the rural area, the prevalence is slightly low. And one study from North India, that is about 50%. So it depends upon the population and also the study. So what is I mentioned that mortality is 69% higher than general population over a period of 28 years. And the cause of mortality, I mentioned that 1/3 is due to cardiovascular disorder, and about 20% is from extrahepatic malignancy, and about 7 to 19% is liver-related death. But the liver-related death is the most important cause in population who are having NASH. But this is the data who are having non-alcoholic fatty liver disease. So the risk factor most important, that these people, either those who are aged more than 50 years with a BMI more than 30, and there is elevation of transaminase, that is ALT or AST, and the diabetes and obese. These are the factors who can have severe non-alcoholic fatty liver disease. And there may be some association with other rare disorder, metabolic disorder like polycystic ovary syndrome and hypothyroidism. So metabolic syndrome, the central obesity, the fasting blood triglyceride level, HDL cholesterol, elevated blood pressure, and fasting glucose. These are the criteria that you should diagnose metabolic syndrome when these criteria are fulfilled. The fasting triglyceride more than 150, HDL less than 14 men and less than 15 women, elevated blood pressure, and fasting sugar more than 100 milligram per DL. So what is the problem of lean NASH, in particularly in Asia? Here, these patients are diagnosed. They have the BMI of less than 24 or 25, but there are all the other factors probably are playing there, and they are having the problem of there may be genetic predisposition, there may be some diet factor, visceral obesity is there. They are not obese, but there is visceral obesity, dyslipidemia. That is the potential role for pathogenesis, and the risk for these other complication and cardiovascular mortality all are same compared to obese NASH. So the diabetes. The problem of diabetes is really with the whole Asian countries. In India, it is almost an epidemic, and the association of diabetes with NFLD is bidirectional. That is, people who have diabetes, there is a high prevalence of NASH or NFLD, and those who are having, you have diagnosed a case of non-alcoholic fatty liver disease, always you search for diabetes, and the prevalence of diabetes is significantly high. And these obese middle-aged female with diabetes, they are more likely to have fatty liver disease on ultrasonography up to the tune of 70%. And in the patients of NASH, the history of diabetes is found to be more than 2.6-fold increased risk of NASH. And the diabetes and high BMI are associated with also progressive disease. So these people who are obese and who are diabetic, they have a more severe disease and fibrosis progression, and there is chance of cirrhosis. You have to be very cautious. Just I want to share briefly about the pathogenesis of NFLD. This is a vast subject, but just I want to outline the brief pathogenesis. Classically, it was described that it is a two-hit hypothesis. The first hit is there is an accumulation of fat, and the second is there is inflammation and fibrosis. The fat accumulates in the liver. The most important factor is insulin resistance. There is increased free fatty acid influx. There is reduced fatty acid oxidation, reduced triglyceride export, and the adiponectin activity is less. And the second, the main pathogenic mechanism, there is incomplete oxidation of free fatty acid in the liver. There is oxidative stress, and there is hepatocyte lipoapoptosis, and there is excessive inflammatory cytokine injury, that is interleukin, IL-6, TNF alpha, and leptins. So this is that when there is insulin resistance, there is excessive free fatty acid from the adipose tissue, and there is excessive load also from the diet. These free fatty acid load occurs into the liver, and there is de novo lipogenesis within the liver because of the metabolic defect. And when there is a excessive lipid accumulation in the fat, there is compensated steatosis. But when there is beta oxidation, but there is a maladaptation of this excessive free fatty acid in flux, there is toxic lipid metabolites accumulation. So there is activation of inflammation, and there is activation of the macrophage. And when there is activation of macrophage, there is activation of the stellate cell, which leads to the liver fibrosis and can progress to cirrhosis. So this is called substrate overload liver injury model. That is the scientists, they have made that this pathogenic mechanism is not in the step by step, it occurs simultaneously. And the main problem of this, that is excessive triglyceride is accumulating in the liver, and when there is lipotoxic injury, and so there is the endoplasmic reticulum injury, stress, oxidative stress, and there is inflammation, activation of inflammatory mediator, and I've already mentioned that is activation of hepatic stellate cell due to macrophage activation, and there is collagen deposition and fibrosis. So what is the presentation? Most patients of fatty liver disease, they are asymptomatic. They are coming to us either due to abnormal LFT or mostly due to the abnormal imaging, particularly by ultrasonography evidence of fat accumulation in the liver. And the lab abnormality, the liver function test can be absolutely normal with patients of non-alcoholic fatty liver disease. And even in patients with NASH, about 20% can have normal liver function test. It is very important. So, but usually if the LFT is very high, particularly AST is less, ALT is more than AST, and alkaline phosphatase may be elevated up to 2 to 3 times. But usually SGOT is less than 5 times. If it is more than 5 times, you should suspect other cause of liver disorder. So usually LFT may be normal, or and transaminase may be elevated up to 2 to 5 times the upper limit of normal. Usually the ALT is higher than AST compared to ethanol, that is alcohol-induced injury. AST is higher than ALT. But when there is cirrhosis, this ratio may be reversed. AST may be more than the ALT. And another important that platelet count, you should think that whether the platelet count is low, that is a marker for liver fibrosis. And as I mentioned, that normal ALT does not rule out the progressive disease, even in the tune of non-alcoholic steatohepatitis. The radiology, I mentioned that ultrasonography is the most common, but it is positive when the fat accumulation is more than 30%. But definitely by pathologically, if the normally the fat accumulates, normal fat liver can have less than 5% fat, 5 to 30% ultrasound may not be able to diagnose. There may be sometimes there may be quantification of grade 1, grade 2, grade 3, but it is subjective, maybe. But otherwise, when there is fat accumulation in the liver, it is fatty liver disease. The other modality rarely necessary, but it is not, it's more expensive, like CT and MRI. The MR spectroscopy, this can quantify fat, but it is expensive but not easily available. But there is some test by which you can assess the global fat accumulation and global fat deposition, and you can quantify the MR. That is more advancement by non-invasively, you can diagnose non-alcoholic fatty liver disease by MR. So this is the picture of the ultrasound, and on the left hand side CT scan, that is accumulation of fat. How reliable is ultrasound? I have already mentioned that consistent NFLD may not be detected when there is relatively less, that is about 20 to 30% of fat accumulation in the liver may not be detected by ultrasonography. There are some tests by which you can have an idea whether there is development of liver injury, like inflammation with or without fibrosis, that non-invasively before going for liver biopsy. So there are some formulas like AST or to platelet ratio, FIB4 index, non-alcoholic fatty liver disease fibrosis score, and some complex parameters are there. And another non-invasive is the imaging is called elastography. So this index, you can have some cutoff value by which you can diagnose whether there is significant fibrosis or not. So that is called NFLD fibrosis score, APRI, that is AST platelet ratio index, FIB4 score, and BIRD score. So this FibroScan, this is a very important tool for assessing non-invasively that whether there is significant fibrosis is going on or not. That is called the FibroScan, or the vibration controlled transient elastography. If the value is more than 9, particularly that indicates that there is significant fibrosis is going on. And if it is in cirrhotic, the value is more than 20 to 12 to 14. So you can have idea. There are some, there is not 100% sensitive and specific, but non-invasive assessment can be done. And as I mentioned, that MR elastography, that you can have a global picture of how much fat is there and whether there is fibrosis or not. And you can quantify the fibrosis, that is called MRPDFF criteria, but this is expensive. So what are the biomarkers? The diabetic has a biomarker, that is HbA1c, by which you can, whether it is pre-diabetic, whether diabetes is controlled or not. But in fatty liver disease, there is no such biomarker, but there is a lot of analogy between these two disorders. So I will describe lastly that what is, but there is the cytokeratin 18. This has been found to be a very important biomarker, but it is not widely available. And so there maybe in future we can have a biomarker by which just without going for biopsy or without going for all the tests I mentioned, you can have an idea whether you are dealing with a case of fatty liver disease, whether there is non-alcoholic steatohepatitis or there is ongoing fibrosis or cirrhosis. So the last is the biopsy. Whether to diagnose the non-alcoholic steatohepatitis, the gold standard is biopsy because it is a histological diagnosis. So, but the limitations of the liver biopsy, it is risky, it is costly, and there is a chance of sampling error. But biopsy should be done when there is an increased risk for advanced fibrosis to confirm whether you are dealing with a case of non-alcoholic steatohepatitis with or without significant fibrosis, and you can quantify the scoring. And this is the indication: a patient who have a age more than 45. The female, the NFLT is more common in male than female, but if in a female gender, if there is an abnormal LFT and high APARI ratio, or the patient is diabetic, or other metabolic syndrome, there is high CK18, I mentioned that the biomarker, high NFLT fibrosis score, high liver stiffness measurement by fibroscan, then liver biopsy should be done. And the lesion, there is I mentioned in the beginning that there is ballooning of hepatocytes and there is mixed inflammatory infiltrate. And by these, you can have a criteria to diagnose that whether you are dealing with a case of NASH or not, the steatosis, ballooning, and lobular inflammation. And when there is fibrosis, it is graded as F1 to F4. F4 is cirrhosis, F1 perisinusoidal. That is usually it is in the zone 3 fibrosis, perisinusoidal fibrosis, predominantly affecting the central area. And when there is a perisinusoidal with portal, that is F2, and when there is bridging between the portal tract and the central area, then it is called bridging fibrosis F3, and F4 is the cirrhosis. And this is the NASH score. I mentioned that the steatosis is graded, lobular inflammation is graded, and the hepatocyte ballooning. And then you can have a score of 5 or more to confirm that it is a NASH. The score of 2 or less, that is a simple steatosis. Now, what is the goals of therapy for non-alcoholic steatohepatitis? The most important, our goal of treating the non-alcoholic steatohepatitis to prevent the liver-related morbidity and mortality and to prevent the cardiovascular mortality and morbidity. As I mentioned, always you have to think of whether the patients of NFLD is having cardiovascular disorder, and then you should take all the care for taking care of the cardiovascular disorder. The most important treatment at present for non-alcoholic fatty liver disease is lifestyle modification. The comprehensive
Chaudhary,
lifestyle modification approach.
Chaudhary,
Either, yes.
You can finish it in, yeah.
Sorry, I have taken only 15 minutes. I am supposed to talk for 30 minutes. Should I?
No.
Sorry, okay. No, it's okay. I can finish very short.
Chaudhary, I'm asking you how long it will take for you. How many minutes?
Another 10 or 15 minutes. Another 10 minutes.
Okay. Just want to know how long you are going to take. That's all. Please continue. Please continue.
Okay. The lifestyle approach is the most important present treatment for non-alcoholic fatty liver disease. You have to go for energy restriction, that is calorie restriction. I will describe that how the NFLD improve with weight loss, and you have to maintain the weight loss. That is very important. And the quality of food, the fructose intake should be avoided. Daily alcohol intake should be less than 30 grams for men and 20 grams for. So social drinking may be allowed in patients of non-alcoholic fatty liver disease, but the regular use of alcohol should be avoided, and they can produce a combined injury to the liver. The macronutrient, that is like low to moderate fat, moderate to high carbohydrate, that is important. And physical activity. You cannot reduce your weight by only dietary restriction. The physical activity is very important. 150 to 200 minutes per week, moderate intensity exercise, in 3 to 5 sessions per week, and resistant training to promote the musculoskeletal fitness and improve the metabolic factor. So by all these, you can achieve the goal of lifestyle modification and improvement of non-alcoholic fatty liver disease. This study showed that the energy and calorie restriction inducing weight loss are the needed to improve the NFL. If you can improve the weight loss by 3%, there is improvement of steatosis in the tune of 35 to 100%. And if you can, if there is weight loss of more than 5%, there is improvement of steatohepatitis, that is ballooning inflammation is improved. If the weight loss is more than 7%, the NASH resolution, it has been found by paired biopsy in future that the NASH has improved, completely resolved. And more than 10% weight loss, there is improvement of fibrosis, there is the documentation of fibrosis regression. So the weight loss is the most important tool for improving the fatty liver disease. But the problem is that in this study showed that only 30% can achieve more than 5% of weight loss. Only less than 10% could achieve more than 10% weight loss. So to achieve that weight loss is really difficult, and more difficult to maintain the weight loss. So the dietary changes and lifestyle is a first-line therapy. Unfortunately, many patients, these measures cannot be implemented efficiently or cannot be maintained in the long run. And many patients have already tried it, and lifestyle modification has been tried, but it is unsuccessful. So others have, and many patients have significant liver disease that is progressive NASH. So there is question that then you should think of other therapy other than lifestyle modification, whether you can halt the progression of non-alcoholic steatohepatitis. That is called pharmacotherapy. The indication of pharmacotherapy, that is NASH with significant fibrosis or early stage NASH with increased risk for fibrosis progression, and there is active NASH with high necroinflammatory activity. But the pharmacotherapy is not recommended for bland steatosis or NASH. You have diagnosed NASH, but there is not much of fibrosis. So most important that pharmacotherapy should be considered when there is NASH with ongoing fibrosis or early fibrosis has started. Because there are a lot of limitation of the present pharmacotherapy. There is numerous trials are going on, and there are data, but still at present there is no recommended pharmacotherapy for NASH other than the lifestyle modification. But you can target that insulin resistant, you can target the lipotoxicity and oxidative stress, you can target the inflammation and immune injury, you can target the cell death, that is apoptosis and cell necrosis, or you can target the fibrosis. So that there are different drugs are available at present. So, and you can combine some of the therapy that by targeting the metabolic pathway or inflammatory pathway or fibrotic pathway. So that is called combination therapy, just like at present diabetic therapy. So there I will discuss about the present therapy, what is the data on vitamin E and pioglitazone. This is the classical PVEN study that showed that the comparison of pioglitazone 30 milligram per day with vitamin E 800 milligram, 800 international per day compared to placebo in a phase 3 trial in biopsy-proven NASH without diabetes or without cirrhosis. That showed that is a significant improvement of NASH compared to placebo in both vitamin E and both with pioglitazone. And this PVEN, there is no significant improvement in the fibrosis. This is important. There is improvement of NASH, but no significant improvement of fibrosis. But this study, another study showed that pioglitazone in patients of pre-diabetic or type 2 diabetic, 1.5 years, 18 months outcome showed there is more than 1 point improvement of fibrosis also. Other than there is resolution of the NASH, primary improvement is the resolution of NASH, but there is also improvement of fibrosis. But there is some problem of safety and tolerability of the vitamin E and pioglitazone. There are some data that there may be, or the higher dose of vitamin E, there is all-cause mortality risk is higher. There is increased hemorrhagic stroke incidence, increased prostatic carcinoma. But these are only few data, but the latest that this may not be the true incidence, and there is not, but vitamin E is not recommended when there is cirrhosis. And the pioglitazone you can give both in diabetic and non-diabetic, non-alcoholic fatty liver disease. The problem of pioglitazone, it produces weight gain, may produce edema. There is some risk of osteoporosis. There is some data that the bladder cancer risk is slightly high, but there is other studies show that it is not so. What is the data for ursodeoxycholic acid? There is some data that ursodeoxycholic acid improve the biochemical response, that is improvement of ALT and AST. And this study over in 2011, there is improvement of glycemic control and insulin resistance. But there is not much of improvement of fibrosis. These studies initially showed that there is improvement, some fibrosis marker, but there is no proof that ursodeoxycholic acid can improve fibrosis. So at present, ursodeoxycholic acid is not recommended in the therapy for non-alcoholic steatohepatitis, but still the lot of physicians and even the gastroenterologists are using it, because at present there is not robust data for the other drugs. Also, the ursodeoxycholic has not been found to be affecting adversely, so that it is not that, but there is at present it is not recommended for from the guidelines from the society, different societies. The metformin, it is effective for glycemic control in patients of diabetes, but there is no data that it improved the NFLD. So the metformin is not recommended for treatment of non-alcoholic steatohepatitis. So statins as a whole, there is some problem whether statin can be more detrimental in patients of liver disease, but that is absolutely wrong. But usually statin can be safely given in NASH, can be safely given in cirrhosis, but it is decompensated cirrhosis, you should try to avoid statin. Then the statin is not indicated for treatment of NASH, but if the statin is necessary for patients with hyperlipidemia, for metabolic control, cardiovascular risk prevention, definitely statin should be given. There is some nuclear receptors which tune up our lipid and fat metabolism, of which there are two important receptors is PPAR, that is peroxisome proliferator activator receptor alpha, beta and gamma, and farnesoid X receptor. And there is two drugs which is acting on these. The PPAR, the receptors, that is nuclear receptors, there are alpha receptors, there is beta control, increase beta oxidation and reduces the steatosis. Gamma receptors, there is reduces steatosis and insulin sensitivity, and alpha delta, there is combination. So there are two drugs that is called elafibranor, which acts on the alpha and delta, and saroglitazar act on the alpha and gamma. And that study showed that the saroglitazar, which is a novel dual PPAR alpha gamma agonist, and phase 2 randomized control trial, that is evidence 4 study, that there is and this is one data that the efficacy and safety of saroglitazar was in one center in Kolkata. We found that it has significant improvement of the parameters which has been assessed by liver stiffness measurement by CAP score, but that is the fat accumulation and the stiffness score. Significant improvement with that is another study which has been presented last year in APDW, that saroglitazar improved the serum improve the transient elastography in diabetic dyslipidemia with NFLD. So the obeticholic acid, I have mentioned that it is a farnesoid X receptor agonist. It has a multiple mechanism. And the data first in the Lancet that we showed, that is called Flynn trial. X receptor like NASH. So there is that clinical trial data has been presented, and that showed that primary endpoint, that is fibrosis improvement by more than one stage, was significantly affected compared to placebo with 25 milligram of obeticholic acid versus placebo. And the NASH resolution was also found to be improved in obeticholic acid of 25 milligram. But this is the first trial which showed that the significant improvement of and so this is on the process of maybe approved in future for the therapy in alcoholics. But the lipids, the higher total cholesterol, higher LDL cholesterol, but that improves just after stopping the drug discontinuation. So whether that is important or not, whether it's pathologically significant, is still not clear. So these are the 4 drugs which is on the phase 3 clinical trial. I mentioned about obeticholic acid, but there are other drugs like Cenipriviroc, which is a CCR2 antagonist, elafibranor, I already mentioned PPAR alpha delta agonist, and Cellon-13, which is the ASK1 inhibitors. These are on the clinical trial, and maybe in future may be effective. But just I want to mention that there is another approach for managing this problem of fatty liver disease called duodenal mucosal resurfacing procedure. But you know that the DMR, this is a procedure that duodenum, there is a area where the different factors are responsible for the metabolic derangement in insulin resistance. And if the mucosa can be resurfaced by endoscopic procedure, then there is improvement of insulin resistance, that is insulin sensitivity is improved, and NASH has been found to be improved. This data that about 85 patients with type 2 DM endoscopic DMR were enrolled, and then so there is improvement of higher HbA1c, fasting blood glucose, weight, and ALT. So this is these studies showed that this is another approach, and maybe in future, maybe that it may be one of the method. There is some data that bariatric surgery has been found to be effective, and there is the improvement of diabetes, arterial hypertension, triglyceride, fasting sugar, insulin resistance, and improvement of ALT after bariatric surgery in patients of severe obesity with non-alcoholic fatty liver disease. And the bariatric surgery improved the fibrosis in patients with NASH. But per se, for treatment of NFLD, the bariatric surgery should not be recommended, but it should be recommended only when there is indication for management of obesity. But the data showed there is improvement of all the metabolic problem and also improvement of fibrosis by bariatric surgery. So the current available pharmacotherapy is pioglitazone, which has been found that in the PIVOT study, this improvement of NASH. There is some study, but still it is not clear whether liraglutide, which is a GLP-1 receptor agonist, that has found to improvement of NASH without worsening of fibrosis. And the targeting the oxidative states, that is vitamin E, and I have mentioned already. Sorry. Okay. So at present, the guideline that pioglitazone can be given and vitamin E for patients with biopsy-proven NASH. In INSL also, their guideline showed that pioglitazone and vitamin E has found to be the most useful drug, are recommended for non-diabetic patients with histological NASH. There is also the other guideline from the ASL that these two may be used, but not in patients with cirrhosis. The vitamin E should not be given, and there is some concern with pioglitazone also. So at the outset, I mentioned that the non-alcoholic fatty liver disease is analogous to diabetes, and there is a biomarker for diabetes like HbA1c, but in fatty liver disease, no definite, but the management is almost same that when there is pre-diabetes, we always encourage for lifestyle modification. So that is true for the non-alcoholic fatty liver disease. But when there is a NASH or fibrosis, then just like type 2 diabetes, when the HbA1c is more than 6.4, definitely you are giving the guided therapy. And also NASH, then liver-directed pharmacotherapy should be tried. But at present, the data I mentioned, it is in still on the process of evolution, and it is still not recommended therapy, or no single drug has been proved by the different society. Only there is some data on vitamin E and pioglitazone. And when there is a cirrhosis, then you have to think how you can manage what are the complications of it, whether there is a cirrhosis is compensated or decompensated. Then you should go for counseling, regular monitoring and screening for varices, screening for hepatocellular carcinoma, just like the problem of diabetes when the patient is having the organ dysfunction like CKD, retinopathy, coronary artery disease. So finally, to summarize, then NFLD has a tremendous clinical, economical, and quality of life burden. Globally, it is a public health problem. NASH is a progressive form of NFLD. Simple steatosis is a benign prognosis, no indication, no need for any therapy. But NASH carries a poor prognosis, and there is increased liver-related and cardiovascular mortality. The lifestyle modification is the foundation of any treatment plan, and there is some evidence for the role of drug therapy for biopsy-proven rash with vitamin E and pioglitazone, and there is some recent evidence on the efficacy of saroglitazar and obeticholic acid. Thank you very much for your patience here.
Well, thank you. Thank you very much, Dr. Chaudhary. And thank you very much, Dr. Chetan Bhatt also. And I think both the speakers, they have given a good justice to the topics which were assigned to them. And this was very interesting and very informative, that how should we treat, how should we manage, how should we diagnose a clinician as IBS, as well as the NFLD or MAFLD, and what are the recent advances as far as the diagnosis and the treatment is concerned. Now, with this, I open the discussion, and there are some questions in the chat box which I am going to take. Well, the one question which is for Dr. Bhatt is, okay, my cam is on or no? Okay. Well, the first question which I would like to take is for Dr. Bhatt, and the question is, let me come to that question first, and that is, one is, there are so many questions that for both the speakers. One is that how long can I use drugs like mebeverine plus chlorodiazepoxide in IBS with anxiety, and what is the dose to be given? Dr. Bhatt, please.
Okay. Now, as long as the symptoms persist in IBS, you have to continue the drug. Now, there are two parts of this question. Part number one is the mebaverine part, and part number two is the chlorodiazepoxide part, which is a mild anxiolytic or anti-anxiety drug. If you talk about a mebaverine hydrochloride, most of the studies talk about a 3 months trial along with the placebo. But in the clinical practice, you can continue more than 3 months. Regarding psychotropic drugs, drugs for the anxiety, depressions, so consensus is you have to continue this drug for 6 months to 2 years. Do not stop this drug moment the patient is little better. If you stop this drug early, patient relapses very fast. So all the psychological drugs you have to continue for minimum 6 months to 2 years.
Okay, good. So it's a long treatment where for a few months to a few years is usually the guidelines which we give to the patients, as usually the response is a little delayed, and there is a sometimes recurrence of the symptoms. So naturally, we have to give for a longer period of time. Sorry. The next question is that how do I clinically suspect SIBO, SIBO in IBS patients? Which antibiotic and how long to use? And do I also give antispasmodic to these patients as they complain of the bloating and pain?
Most of the time, IBS symptoms are mainly related to the bowel habits, abdominal pain. But in India, most of the IBS people, almost 50% people have upper GI symptoms also. So now that makes us difficult for us to differentiate between SIBO and IBS symptoms, because SIBO will have bloating, change in bowel habits, loose stools, 3 to 4 stools, umbilical pain, periumbilical pain, and dyspeptic symptoms. So clinically, if you suspect strongly SIBO, you can continue giving drugs like doxycycline, or you can give rifaximin hydrochloride of 1200 to 1600 milligram. Give for 10 days to 14 days, then stop the drug. The beauty of this drug is that you can repeat the drug at least 3 times a year. There is no side effect. There are enough studies done that continuous use of this drug does not produce any resistant bacteria in the GI tract. And every time you restart the drug, it is always responsive, and there is no problem using it for frequently in a year.
Well, antispasmodic, can we use antispasmodic in this? Because these patients, they complain of abdominal pain also.
Most important here is do not use a drug like dicyclomine hydrochloride. Please use a drug like mebaverine, which is a mild antispasmodic, and it is also a gut motility regulator. So which gives you a better result compared to a drug like dicyclomine hydrochloride, which will produce a dryness of the mouth, or a drotaverine hydrochloride that you reserve only for the moderate to severe pain. Mebaverine will do the trick for the mild to moderate pain.
Okay. And the next question is that how long should probiotic be used in IBS and SIBO patients? Any specific probiotic to be preferred? Dr. Chaudhary, I'll come to this question. I'll put into you as well. First, Dr. Bhatt.
See, probiotic studies, most of the probiotic studies in IBS cases have proven that it is not better than placebo. But irony of the practice is that we all still use up and end up using the probiotic in our practice. So problem is that how long to continue probiotic. Most of the probiotic available in markets are very expensive, cannot be continued for a very long time. So what we do normally, we give it for the period of 6 weeks to 3 months. Some people advocate probiotic as a daily routine, lifelong, for a very long period of time, but that is not ideal. If you are using along with the antibiotic, then use a probiotic like a Saccharomyces boulardii, which is partly antibiotic resistant and which can be given with the antibiotic. Most of the time people make mistake, they give antibiotic and they give probiotic. So that should not be done. If you are giving rifaximin hydrochloride and you give probiotic also, so there are no studies that a probiotic will be useful. So after you finish the use of antibiotic, then you use the probiotic for a period of 6 weeks to 3 months.
Yes, Dr. Chaudhary, any comment from your side on this? The use of probiotics?
Actually, what Dr. Bhatt said, that this placebo response is significant, and there are a few studies that the probiotic may be effective in IBS, particularly IBS-D. But definitely that if the response is there, you can give the treatment for about 6 weeks to 8 weeks or 12 weeks. But don't mix with the antibiotic, and probiotic should not be combined. And the combination therapy is we always try to avoid it. And theoretically feels that probiotic may be effective, but there is no robust data that probiotic is very much effective in patients of IBS.
Right. Thank you. And then the next question comes to Dr. Chaudhary. That's for him. That clinically, we will assess NASH with cholestasis.
NASH with
Assessment of
cholestasis.
That's right.
Sorry, NASH with cholestasis.
That's right. That's right.
Actually, I have already mentioned that that if the abnormality, particularly the liver function test abnormality, suggests something other than that, then you should try to exclude the other cause of liver injury. Particularly, cholestasis is not known to develop in patients of cirrhosis, other than except in patients who are on therapy with obeticholic acid. There may be some itching problem, but not cholestasis. Cholestasis means high alkaline phosphatase with high bilirubin, and the patient is having symptomatic itching. Then you have to think that if this is not a NASH, you should try to that whether it is primary biliary cholangitis or not, whether there is any drug which can produce cholestasis or not, or any other disorder which can produce cholestatic disorder. And then you have to find out that when the patient of NASH having features of cholestasis, then you have to think that it is that there must be something more than NASH or something added with NASH.
Well, the next question probably you have already answered, that what is your experience of ursodeoxycholic acid in NAFLD or NASH? Is there any specific you have to say?
Actually, what I have told you that scientifically the UDCA is not recommended for treatment of non-alcoholic fatty liver disease. But I have said that we, the physician, gastroenterologist, even we, so when the patient is coming to you with a diagnosis of fatty liver disease, they have a they want from the doctor that something you can give, you should give. The most important that you have to assess whether this patient is really having a NASH or not. That I mentioned, that whether the patient is obese, whether there is other metabolic disorder, then you should try to diagnose whether there is a progressive, that is NASH, or it is just a bland fatty liver disease. When there is bland fatty liver disease, I don't think that any treatment is necessary. But okay, ursodeoxycholic acid has been found to be effective in improvement of liver function test abnormalities like ALT and AST, but there is no data on improvement of fibrosis. For that, actually, at present, it is not ready.
I think for that, the lifestyle modification, the diet control, these are more useful rather than UDCA itself or any medication.
That is the cornerstone of therapy of health.
That's right. That's right. So how long, the next question is, how long should I use UDCA and when do I need to repeat the investigations?
Actually,
and you said that it should not be used at all, rather it's not effective. So you can, the clinician can use on his own will, although there are no evidences and no supportive evidence to say that should be used.
Yeah, okay. I agree with that there is no supportive evidence.
Yes. Well, the other question is, obeticholic acid, as per the recent report, is not approved by FDA and dose used in the studies is high. Do you think that there is any benefit of OCA with this subtherapeutic dose commercially available preparations in India in NAFLD or NASH?
Actually, even in India and also in FDA has approved this medicine for primary biliary cholangitis. Those who are, that is PBC, who are not responding to ursodeoxycholic acid. So okay, but there is some the definite data which suggests that obeticholic acid may be recommended for non-alcoholic steatohepatitis, but it is till now it is pending, and there is only the suggestion that it improves the fibrosis. Maybe in future it may be recommended, but the data is on 25 milligram, and with the 25 milligram dose, there is improvement of fibrosis. But at present in India, the most the pharma companies has brought 5 milligram and 10 milligram tablet, and that the people and even ourselves, we can use it. But if you really want to give therapy, then you should gradually increase the dose to up to 25 milligram per day, because that is the data which has shown to be effective. So it is not that you can give though it is available as a 5 milligram, you can give 5 tablets for 20 or 25 milligram, but that it should be given in a incremental dose, because there is a side effect of pruritus.
Okay. Okay. Dr. Bhatt, there is a question for you also, that how do I manage the patients of IBS relapse? Because usually the relapse is very, very common in these patients. So is there any specific therapy where we should try to check the relapse as such, which is so frequent in some of the, in the majority of the patient, I would say?
This is a very good question and a difficult question to answer because IBS never gets cured. Simple.
Yes.
People have done a study that even after 19 years, 20 years, IBS symptoms remain the constant. And IBS patient keep visiting the doctor. So number one. Number two, diarrheal variety IBS carries a better prognosis compared to constipated variety of IBS. And in between the two, any patients with a IBS has a somatization syndrome, that is a headache, body ache, neck pain, or particular side body pain, or there was psychiatric comorbidity, then it is very difficult to treat. So, but still, with a good treatment, he becomes all right. Do not stop your treatment for 2 years minimum at least. And if you refer them to a psychiatrist and they are proven to be having a psychological trait or underlying psychiatric disorders, then you can continue your treatment for 2 to 5 years also. So, what is most important here? The IBS drugs, you can decrease the dose, but do not stop the drug for 6 months to 2 years. You can change the diet, you can change the lifestyle, you can reassure the patients, you can decrease the dose, but don't stop the treatment. Even if you stop the treatment, keep the close follow-up and keep the dietary advice, low FODMAP diet, gluten-free diet, keep changing the diet, give elimination diet, and as and when the symptoms arises, you can give treatment for some period of time. But ideally, the patient continues to have treatment for a significant period of time, at least 2 to 5 years.
Right. Right. And is there any benefit of peppermint oil role in managing IBS pain?
Peppermint oil has been used. It was used in the past 25, 30 years ago. Now it has come back. It is mainly for the pain variety of the IBS, the mixed variety and the pain variety. It is helpful in the pain variety. But only problem with peppermint oil is that people do not realize that if you take it, you have a severe burning in the rectum and the anorectal area. So side effect of the peppermint oil. So use
Okay.
it for abdominal pain.
Mhm. And what are your views on ramosterone in IBS D patients, and what dose should be preferred?
See, the dose which they promote is a very high dose, oral dose than IV dose. But I do not recommend for the Indian IBS patient because it is not been very successful. Simple loperamide tablet is good enough for the IBS patients, or a mebaverine hydrochloride. The problem with the diarrheal variety is that most of the diarrheal variety, they are not diarrheal variety, they are alternating variety. So moment you give one tablet of loperamide, they get constipated. When you give treatment of constipation, they get diarrhea. So what is most important is to just give a small dose of loperamide and mebaverine hydrochloride. That is very important. That is best treatment. Ramosetron, I don't use it, and in last my 5 years, hardly one patient I must have used it because I am scared of the side effects.
That's true. That's a very, very important information which can be given to the clinicians who are treating IBS patients. Well, is there any tapering of dose required during the management of IBS with anxiety patient, as mainstay of the treatment in general is GABAergics used along with antispasmodics? Is
Yes.
there any tapering of the dose which is required?
Yes. See, you start the dose initially in a small dose, titrate the dose till you reach the optimum dose. This takes on average 3 to 6 weeks for you to reach the optimal dose. Most of your psychological drugs or even a GABAergic drugs takes on average 3 to 6 weeks to have a maximum effect. After that, you optimize the drug over a period of next 3 months. Once the patient's symptoms are well controlled, you decrease the dose to the minimum tolerable limit. If the patient has drowsiness, dryness of the mouth, or a change in bowel habits, you decrease the dose. And the optimal dose you continue for a longer period of time. My secret of IBS treatment is that I do not use one drug in a full dose. I use combination of 2 or 3 drugs in an optimal dose, so I do not get a side effect of any drug. Sometimes I use the side effect of the drug to treat the primary symptoms. Because, for example, if you use SSRI, correct? So SSRI side effect is basically diarrhea, increased frequency of stool. So what I do, I use them in a constant, so I get a side effect like a diarrhea.
That's right.
So I use SNRI. SNRI side effect is a constipation. I use them in a diarrheal variety. So I get an adequate response in a primary symptom also. So you have to optimize the drug, but do not stop the drug for 6 months to 2 years.
That's right. That is the crux, and that is the main important message which should be given to the clinicians to use it. Well, Dr. Chaudhary, this is for you. That what is the first line of the treatment of NAFLD and LSM, and what stage I need to shift the patient to hepatoprotective medical management?
I have already mentioned that you have to assess that whether the patient is having the features suggestive of non-alcoholic steatohepatitis, and when there is without fibrosis, that suggests that there is a significant chance of progression to chronic liver disease like cirrhosis and its complication. Then you should take all the steps that how can you halt the progression of the disease. And as I mentioned that there are some the data on vitamin E, and there is some data on pioglitazone, and there is saroglitazar and the obeticholic acid. You can choose anyone. You can choose, definitely.
One important question which has come is there any role of the herbal hepatoprotective drugs? They have got any role in NAFLD?
Actually, there is no scientific data, and sometimes we have the experience of herbal drug do more harm than doing good in liver disease, and we have the experience that herbal drug has produced acute liver injury. But there is some data that the Chinese alternative medicines, there is some of the drugs may be protective, but there is no scientific data.
Okay. And till what stage of the fibrosis in NASH can be reversed? Whether transient elastography is enough or liver biopsy needs to be done?
There are two parts of this. You have asked about the one is that at what stage this fibrosis can be reversed. I have shown the data that by retrospective analysis and paired biopsy that the bariatric surgery, there is improvement of fibrosis even to the stage 4 fibrosis has been reduced. So the fibrosis stage can be improved by treatment, by intervention for managing the problem of metabolic disorders like non-alcoholic fatty liver disease. But the liver stiffness measurement by FibroScan cannot assess that whether your treatment is sufficient enough and whether the patient is responding to your treatment. So the gold standard is liver biopsy, but for clinical practice, it is not possible to do repeated liver biopsy. So only thing, the other guidelines can be helpful, and even you can take the action of the FibroScan whether the stiffness is going down or not. Definitely.
Well, I think there are 2-3 or more questions. That role of linaglutide in IBS. Yes, Dr. Bhatt, role of linaglutide in IBS.
Actually speaking, is not very useful in my practice. I have never used it. I have no personal experience of this.
Well, Dr. Chaudhary, would you like to comment on this?
Liraglutide is a GLP-1 receptor antagonist, so it is mainly for acting on the insulin sensitivity and diabetes, and also there is some data on fatty liver disease, but I have no knowledge about whether it is effective in IBS.
Yes. So Dr. Chaudhary, one question for you again, that should statins be given if lipid profile is normal in NAFLD?
Actually, you have to assess what is the cardiovascular risk of your patients who you are dealing with an NAFLD. If the cardiovascular risk is significantly high, and even it is recommended that if the lipids are normal, you are giving the statins for risk reduction of cardiovascular risk reduction only. But otherwise, for treatment of NFLD, the statins are not indicated.
Well, I think we had a very nice discussion, a wonderful lectures by both the speakers, Dr. Bhatt and Dr. Chaudhary. I must to thank both the speakers for a wonderful deliberations. Of course, a lot of thanks to our participants, colleagues also, who have put on a lot of questions. And thank you once again to both the speaker for answering and clearing the doubt in the minds of the clinicians in their day-to-day clinical practice. I once again would like to thank Abbott Company also for giving us this platform to discuss this evening a wonderful topic, very important clinically for all the clinicians to practice. Of course, difficult patients, but then one should have little patience in treating these patients in their clinic. Well, with this, I'm coming to the end of the session. Would like to invite Mr. Jyotishman. Jyotish is currently working as the head knowledge management and strategic affairs at Abbott, and would like to invite him for a vote of thanks. Jyotish, please.
Thank you so much, Dr. Soni. It is indeed a real pleasure to associate with the Associations of Physicians of India. Such a wonderful job that is done by Dr. Soni, and thanks to you for starting the program today with such a high. I would like to start from the top, starting with the President of Associations of Physicians of India, Dr. S. Arul Raj, for giving us the opportunity to collaborate with the top physicians body in the country for such an initiative. I would also like to thank Dr. Mangesh Tiwaskar, the astute Secretary General of Associations of Physicians of India, and Dr. Shashank Joshi, the Dean, Indian College of Physicians, the Kambam mentor and a very close brother. I would also like to thank today's faculties, starting with Dr. A. Muruganathan, under which the leadership the API DIAS has started. And faculties, Dr. Chetan, but such a wonderful presentation done today on IVS. Thank you so much, sir. I'm sure the delegation will be definitely they got benefited from your presentation and the tips given over there. Thank you so much, Dr. Chaudhary, for such an elaborate presentation on NFLD, and kudos to you for covering the length and breadth of NFLD, including MAFLD, which is an eye-opener for layman people like me, and it is basically to understand. Thank you so much for such a nice deliberation. I would also like to thank all the delegates that are present today. And before that, I would also like to thank today's chief guest, Dr. Agarwal, who has taken out his time from his busy schedule to address today's audience as a chief guest. Thank you so much, the entire medical fraternity. I would also like to thank, my fellow colleagues from Abbott, Mr. Sunil Behra, the general manager and country head of Abbott Rapid Diagnostics, the entire medical team, headed by Dr. Sri Rupa Das, the Kushal, the Vinod, and the team from the marketing, Shanta Prasad, as well as Darshana and Ankit, and also my colleagues, Dr. Kabex, as well as Somya. Also, I would like to thank the entire team from Food Factor, who has done wonderful job for the logistic coordination for the event, headed by Swati Iyer. Would like to again thank Dr. Naveen Kumar Soni. Soni sir, thank you so much. You have really done a wonderful job, and who could have done it better than you, sir. Thank you so much.
Thank you very much. It was wonderful interacting with all my colleagues, my seniors, my friends, and even the faculty and yourself for all the support that you have provided. It was a wonderful evening.
Thank you so much, and do tune us actually for the next event tomorrow, which will be focusing on the URTI. Of course, your own program at a prime time, weekend API.
Thank you very much.
So much.
Thank you everyone.
Thank you.
ಇಲ್ಲಿ ಶಾಂತಿನಗರ್ ಬಂದು ಫೋನ್ ಮಾಡೋಣ ಬರ್ರಿ